Welcome to Innovation Spotlight. Innovation is key to better care and outcomes. Join us as our clinical and administrative leaders examine our successful innovations, as well as the outstanding problems we're still trying to solve.
So today's episode and today's spotlight is on predictive analytics and the work that we're doing on predictive analytics. I'm going to introduce our guests to you today as they start speaking. So I'm going to start with Dr. Khurram Nasir, who is one of our incredible physicians, clinicians, and researchers here at Houston Methodist. And I feel very blessed that he joined us a number of years ago. So he's going to speak to us and start us off today on what is predictive analytics, what promise does it hold, kind of where is it today, and where do we hope it will be in the future?
That's a pretty loaded question to start with, and I'll just try to simplify for most of us to understand. Basically, predictive analytics is using all the inputs, what we call data points that we have gathered passively or actively over the course of time to clear the noise and guide us, our decisions and actions. Now, as within humanity, we've been doing that for thousands of years. As physicians, we've been doing for hundreds of years. We train and educate ourselves for decades, which we call experience. And some of us are able to synthesize and process them better than others. And we think those are the experts, innovators, and leaders, many of us here today. Now, the issue has happened that especially over the last 10 to 20 years, we have seen an exponential increase in the data that's pushing, I would say, the boundaries of our ability to process that. Thankfully, here walks in, I would say, computational sciences, big data, AI, computers, that is helping us go over the intuitions that would have taken decades for years. And especially with the EMR that's accumulating, I think so that was a big step over the last 10 to 15 years that has allowed us to gather a lot of that information. Now, other industries are doing it very seamlessly. Just this morning coming in, Waze told me which streets to avoid. I think so the geospatial data a few weeks back prompted us much earlier what action should we take as a system. And across the other industries, you're seeing like proteins are being discovered that would have taken all the labs in the country working for decades. However, what we're seeing in spite of the fact that we have EMR, most of us at the front end have not yet seen what I would say true impact in how we practice medicine or even conduct research. And the reason is because most of the data so far has been siloed, fragmented, underutilized, and we just don't have the playbook in making the best use. However, at the same time, I think so computer sciences, data analytics, and a lot of our partners, be it academics or amazing industry vendors, are coming us and showing us the way in how we can do that. And I think so that is the promise that holds in the predictive analytics. We are at a stage one of this. We are lagging behind, but for us, I think so this is the Manhattan project in healthcare, where we can bring in together not only all the experts, we have one of the most immense data resources and the investments to really make sure that we are transforming healthcare, and that is the most promising thing. And in this regard, I can tell you that we're seeing a lot of activities within our system over the last few years, and that is the most exciting point. So love to discuss more and some of those going into detail, but just being very excited about the opportunities that present to all of us today by predictive analytics.
So Brenda Campbell, moving on, who was one of our executives here at Houston Methodist over our DeBakey Heart and Vascular Center, as she sidestepped and decided that she was going to slow down a little bit. She made a decision to keep predictive analytics as a passion project and continue working with us around this. So Brenda, as I turn to you, the electronic medical record, as Dr. Nasir, as Khurram has said, it holds incredible promise. There are bazillion data points within the electronic medical record. Yet, despite the fact that there are a million different data points in that medical record, it's not enough. Like, speak about the predictive analytics that we have kind of in that electronic medical record and why at Houston Methodist we needed to go well beyond that to pull in even more data to really do these predictive analytics on our current patients.
Well, thank you, Roberta. And as you said, there are several thousand million data points in an electronic medical record. And because of that, it becomes so complex that, yes, we're entering in a lot of data in that medical record. But then how do you take that information so that as a clinician, whether I'm a nurse, a physician, social worker, how do I take all that information out and how do I understand it? And what has been really interesting is really to take and look at multiple encounters in a medical record. And so as I'm looking at a medical record, not only am I seeing a point in time, but I'm also able to, with the work that we're doing, is look at multiple encounters on the outpatient side, on the inpatient side, and through that whole transitions of care. Now we have a better look at the complete patient's medical record versus just a point in time. And so if I'm a clinician and I'm trying to find a piece of information in the medical record, as Dr. Nasir has said, and also as Dr. Menn has said, us as clinicians, our time is very, very valuable. And how do we go and look in a medical record and find maybe that one important piece of information that could help us in planning for the clinician's plan of care? So now with the predictive analytics and integrating it through the electronic medical record, we're actually creating not just predictive risk models, but we're also working on chart summaries. How do you pull this information, get it easily into the clinician's hands so that they can make the decisions? We're not here to make the decision for the clinician and tell the clinician what to do. We're here to give them that information easily accessible in a way that is easily to be understood, and then they can make those decisions. And what I think is really important is also help the patient and the family be a big part of that care with more information available.
So just building on this, one of the systems that we kind of chose to bolt on, that we chose to say an EMR is not enough, is a system that actually held data for 20 to 30 years of Medicare data and all payer data. Why is that important?
Well, I think it's important for multiple reasons. Yes, about 20, 30, maybe 40% of a hospital's, patients are under the Medicare payer. But when we engaged with an outside predictive analytics company, they had information to all Medicare payers, all patients across the entire country. So now what we're able to do is not just look internally and say, yes, are we doing well or are we not doing well? It gives us the ability to start to look externally. And what also we're able to do is to do some what we call twinning, comparing our patients, exact patients, not just saying, well, using a case mix index or using kind of similar type of patient traits. We can actually go out and working with this company, twin our patients and find that exact patient, sex, gender, age, socioeconomics, comorbidities, and say, how are we actually doing compared to the rest of the country? And then it allows us to say, what are some quality improvement projects that we can also put into place?
Okay, I'm going to come back to that as we talk some exact examples, but I want to introduce Dr. Zach Menn, who actually is one of the leaders in our ACO. So Zach, you also then took this kind of predictive analytic approach, which many ACOs are doing, right, to see kind of what's happening with your patients. But you've successfully, in an incredible ACO, had great results with the use of predictive analytics.
Thank you. Yes, so the issue that you have in an ACO and any kind of population health program, you've got a ton of patients and not enough staff to take care of them. So in order to have the results that you need, you're going to work with the highest risk of that population and put as many resources possible to those that are going to have a negative event, somebody that is going to have a hospitalization. You want to work with them to try to prevent that hospitalization. So that's where predictive analytics is key. Again, to your point about why is an EHR, electronic health record, not enough? Your patients don't always go to your hospital, to your physicians. You need to know the full story. And so that's why we need claims data that tells you a full picture, kind of a longitudinal story of every place that patient has been, what has happened, every hospitalization, emergency room visit, physicians that they're seeing that we may not know about in our EHR. We've got to collect all of that data and paint a true picture of what's going on with that patient. And it gives you a more robust prediction of what's going to happen. So that's why we've done very well with this outside predictive analytics company, truly looking at everything that's going on with the patients and putting our resources towards the highest risk of our patients.
You know, I think this is now getting into kind of, we had this big data, use of more than just what we own, right? We love the fact that the EMR tells us what's happening when they're in the hospital or in the clinic. And if we're lucky, the physician goes back and looks through, the last 3 hospitalizations and 6 clinic visits and whatever it is. But that's really hard. In one stay, a patient can have, basically hundreds of notes, and it's exhausting enough to look through those, let alone be able to say, based on that, what do we think? So many of our physicians are in the moment, right? In the moment, and actually thinking at what will happen, right? There are 2 ways they're trying to think. What's going to happen clinically if I do something, right? What's going to happen after they get home based on the clinical situation that they're in? So going to Brenda first and then back to Khurram, we looked at this, right? We bring in this system that now has information that we can twin, that has data out 30 days, 60 days, a year out, and says, this is based on twinning your population. This is what we think will happen to that person in these 16 different areas. Like, are they likely to come back? Are they likely to die? Are they likely to have a stroke? Are they likely to have these kind of things? You looked across and introduced this concept to all the different service lines. And there was almost this feeling of, I'm overwhelmed. I don't know what to do with that. That can't be right. Like, speak about the initial experience, because people come to me and go, how did you introduce this to your organization?
Good point. And so we introduced it to the organization really starting out in our cardiovascular services. And one of the things that we were asking ourselves is, why are we not staying maybe with our competition in mortality? And I think traditionally hospitals and most administrators, except for maybe Dr. Menn, who works on the ACO side, will look traditionally at what's happening with inside of my hospital walls. And so when we engaged with predictive analytics, we started, as you said, to say, okay, these are some risk factors. What really is happening once our patient's discharged? And what we really found is we were phenomenal on inpatient mortality. Absolutely phenomenal. And that's one of the things that we get constantly. I hear that always today. Well, we're fine. And it's like, okay, but now let's take a look at what happens after your patients leave the facility. And where are they, especially in that first 30 days? And I think healthcare traditionally has always focused on a 30-day readmission. I talk to very, very few clinicians and even hospitals across the country. Oh yes, we know, and we're working on 30-day readmission. My next question is where are you on 30-day mortality? And that usually is where you get the silence. And so by bringing in the predictive analytics, we're now starting to say, okay, let's manage our patients inpatient. That's great. But let's also manage them post-discharge. And I love it because many people say, well, discharge planning starts on admission. Well, yes, but what factors are you looking at, and how can you continue to look at your patient so that discharge planning also extends beyond, and where's the right thing to start working with patients and family to prevent readmissions, but also to prevent mortality where we can. Now, one of the areas that we're also looking at, and people refer to, is when do you bring palliative? And again, there are certain risk factors. The medical record is constantly, updating these risks, but we're not telling clinicians what to do, but we're giving them the more information to make the best discharge plan, to make the best inpatient plan, but also to make the best discharge plan. And learning from our ACO partners in how they actually look at the whole transitions of care, and now bringing in the predictive analytics and the modeling and the risk, we're actually saying we can't, nor should we do everything for every patient. But when we look at these risks and we start to do risk profiling and we start to do risk stratification, how can we bring the best resources, allocate some very, very crucial resources that can be quite expensive, and how can we allocate those to the right patient population so that we can make the biggest impact for quality in patient care?
Right. So Brenda comes to cardiology and cardiovascular surgery and marches in and basically says, hey, your 30-day results, not so good. Right. And so Dr. Zogby, our chair of cardiology, and Dr. Lumsden, our chair of cardiovascular surgery, turn to Dr. Nasir and basically say, hey, Brenda has this new system with HDAI. We've bolted it on. It's doing this predictive analytics. Here, go fix the program, right? And you are the recipient of this. So what's it like to be on the inside to convince your colleagues that now before they hospitalize, before they do surgery, before they do anything, they need to check yet another system to decide on not just the right clinical button that they've been trained in, but maybe what's the right outcome because this patient may have a different untoward pathway that they're going to take?
I would say it has been a wonderful journey over the last 2 years, and learned a lot that I never expected. First of all, when it started, I had pretty healthy skepticism that it works. This is how most of our physicians is. Look, you have to show us what does it mean. One of the key elements, of course, as custodian of excellence, I think so. The spirit was, look, we can do better. We definitely know we are doing, as Brenda pointed out, amazingly in-house. But why is our 30-day mortality not comparable or reflecting that? The reason is, which you just pointed out, the limitations of the EMR. EMR is fantastic, but it does not provide us the whole journey, and especially within that time frame that we wanted. So I think so. I was truly amazed and humbled by working with our colleagues and understanding that one of the largest data assets that have accumulated almost of millions and millions of all the Medicare patients. Now, what it really told us, it gave us the journey, what was happening after they were discharged, their readmissions, their mortality. But the most important skepticism was, we are a tertiary medical center. We see the highest of the highest risk. I think so. The one thing that really helped us understand that how do we compare to other systems who deal with similar patients? I think so that digital twinning piece was critical for us to understand getting on board. The third piece of the skepticism that was all around our physicians is, these models have been created with Medicare data, but our patient population is different. I think so. Getting over that hump, the best part was really developing and validating that again within our own system that clearly showed. Now, and again, once predicted, the question is how well it is. For us, the best part was we see thousands of patients. We have limited resources and attention among those who are the ones who we should pay more attention. And it was the degree of, I would say, ability to distinguish the noise. For example, it helped us identify, if you focus on 20% of the patient, 200 of the 1,000, actually you will be able to capture 80% of the mortality. I think so from a population health perspective, that is one of the best differentiator, whereas, yes, you may not have to pay attention to the 40% of those where only about 2 to 3% of mortality is happening. I think so that was a key eye-opener where it helped get a lot of buy-in from our generally skeptic physician community. However, I thought this was hard. This was the easy part. The hardest part now, how do we implement it? And it's still an ongoing process, but we had a lot of early successes. And in that process, we felt and we found out that actually simplifying the information and keeping it to the basics would rather work. Rather than giving them 20 predictive analytics, can we come up with a simple mechanism? With the click of a button, you can access the score. And as soon as you access the score, it gives you a green, orange, red my conversations with my colleagues and fellows was check, recognize, discuss. And then, of course, if we want to have them see in the next 7 to 14 days, whose responsibility is going to be? Of course, a lot of that time is being set to the discharge teams, but the challenge we're learning that patients do not want to be seen in the next 7 days unless and until we, the physicians, have emphasized it. So in essence, that is the more challenging part that's happening, but clearly highlighting the fact that not only you need your own EMR data, and by the way, this scoring system has been further refined by 11 to 15% by using our own EMR data. So a combination of that would work, but it's not just the data, is we have to get a sense, what are the operational needs? What are the barriers? What do our physicians want? Because in the end, I can bring in the best predictive model if I cannot get the trust of either the physician or the operational leaderships. It's just another tool, will have no impact on what we are trying to do, which is improving outcomes, operational efficiency in a very cost-effective manner.
I think all three of you have mentioned it, but let me just, dig into this for the time being. What I've seen move here in many ways with using this level of data now is a conversation that's moved from every patient needs a 7-day follow-up.
Sure.
Every patient needs a 14-day follow-up. Every patient must come back to us in person. Every patient, can go to whatever nursing home they want to a slightly stronger message on, you're fine. You're good at 30 days. We don't need to concentrate on you. I don't need to hire 15 coordinators to get every single one of you in and chase you down to the end level. You need to come in, but you're fine. And I can just do a video visit on, and it won't matter. That focus on who needs and what type of resources. We talk about personalization of medicine, right? Medications. We talk about a personalization of treatment, but this is a personalization of visit length, visit type, where I'm putting coordinators, where I'm kind of enforcing conversations, or in some cases where I shouldn't be doing a procedure that I was thinking about doing. So speak about those resources, because I know that kind of all three of you have touched on that.
Well, I think it's funny, is that when you speak to one of the easiest ways, and I kind of smile about this, but one of the easiest ways to impact 30-day readmission rates is follow-up appointments. Now, most providers will say, as you just alluded to, I need more resources to do that. When we look at our own data, and when we look at national data using the Medicare databases, 14 days for a high-risk patient, and a high-risk patient we have defined in our organization, high risk for 30-day mortality and or 30-day readmission. If you do a 14-day or less follow-up rate, you significantly impact both readmission and or mortality. If you wait and extend that out towards more of the 30-day, then you don't see the gains of that. And so this 14 days, even nationally, has been shown to be a valuable initiative. Sounds easy. It isn't. You have pushback from, clinicians' offices. I can't schedule that many patients. I don't have that many appointments. The patients won't want to come in. Actually, what we're doing is we're seeing the lower risk patients faster post-discharge, and we're seeing the sicker patients usually when they're coming back to the emergency room. And we have to flip this paradigm, and we have to say, just as you said, using predictive analytics, which patient could maybe extend that beyond that magical 14 days, free up some schedules, and then how do we make the biggest impact to that? But not easy, but we're working on it. And as we start to show what happens when you do see these patients in 14 days and they're starting to see their readmission rates going down, then they become true believers in the initiative.
Zach, you're doing this in the ACO, right?
Yes.
You were probably the primary use case that
Yes.
latched onto this within a nanosecond, and we had no problem selling it to you.
Oh, absolutely.
I mean, why?
No, we are managing our patient through full coordination. Houston Methodist coordinated care. Our goal is to coordinate that care and not drop the ball and not have them come back. So we've got an inpatient team that is working specifically with all the patients in our ACO. They're doing the discharge planning and they're thinking long-term. It's not just stopping the 30-day readmission. I'm responsible for a calendar year total cost of care, every outcome that happens to that patient. So I'm setting up 30, 60, 90 days of keeping you healthy at home. But the key to that is setting up this discharge appointment, making sure you're seeing somebody within the appropriate time period. Like you said, the top 20%, top quintile of risk, I want to get them in within 7 days. I know you mentioned 14, but for that highest risk of mortality or for readmission, I'm getting those in 7 days. The next quintile, those are the 14 days. And then anything below that, that's the ones that I'm going to get 14 to 30 days. We also have our nursing programs. Our nursing team is calling those patients within 24 to 48 hours of discharge. They're working with the high-risk patients, making sure they have transportation to the follow-up visits, making sure they picked up their medication, making sure that if home health was ordered on discharge, did it show up? Did DME show up? I want to make sure everything is done there. They know what medications they should be taking, so they're not coming back for something that is an easy fix. Then they call the next time after the first follow-up visit and say, what did the doctor say? Right? I want to make sure you understood everything that was, told to you at that visit so that you're not going to come again back to the emergency room because there was something that you didn't understand in that explanation of what is going to keep you again healthy at home for the next 30, 60, 90 days. But we are quick to grab onto something, change, we move fast, and we want to have the best outcomes for these patients. That's just kind of the nimbleness of a smaller ACO managing a larger population of patients, as opposed to the hundreds and hundreds of thousands of patients that you see at a hospital level.
So talk about the difference between, our EMR, right? Epic has a good module for the ACO, right? Healthy Planet. It's like
right.
Everyone can say that's fantastic. Mm-hmm. We layered on this predictive analytics kind of HDI program as we did it, and we layered that on. How did that change your world?
Huge, night and day difference. So the issue with analytics versus predictive analytics. Analytics is just looking at the past. How did you do? Right? What are your outcomes? Predictive analytics is saying, how are you going to do in the future based on all the information from the past? Well, the original modules that you have of any kind of risk tool is only as good as the information that's being fed into it. And so in our EHR, it was looking at only a few things. It's looking at the problem list, which may not always be updated, right? And so it's only as good as an accurate problem list there. It's also the original state of it was only pulling from defined fields in the EHR. So if it was something that was free texted, it's not captured in that risk score. The third thing was it was only looking retrospectively. Now, when we got this new program in, we're looking at the history of claims and everything that has happened to this patient before they showed up to this visit. And actually before this group, we were working with another team of predictive analytics that was looking at claims data and a little bit of lab data that was fed into it. So it was pretty good. The issue was it had nothing to do with this hospitalization. And so until this group came in, and I love your example about real-time traffic, the Waze app, it tells you I'm going to look at how the traffic has always been along this route. But what they also have is there's an accident that has currently happened. And so now we have the combination of claims data from the past, the EHR data of what is currently happening in this hospitalization to feed a better predictive analysis, a better prediction of what's going to happen with this patient. And now we have a good idea of what's the mortality actually going to be based on everyone's Medicare claims from the past, this person's Medicare claims from the past, and now what has happened in the past 7 days in this hospitalization. That's been the biggest step forward for us in really refining a prediction of what's going to happen with these patients. And that's when we know, okay, that's someone I truly need to focus on. And our nurses are using their nursing judgment and are getting into the clinicians' offices. Based on that, we're identifying, we are really getting the right patients this time. In the past, it was, I don't know why this person's high risk, or why wasn't this person high risk? They're a mess. I really have a lot to do with them. They should have been brought to me. I feel like now we're getting to the point that when we say they're high risk, I'm getting agreement from nursing, I'm getting agreement from administration and analytics, agreement from the physicians. Everyone understands this is truly a high risk patient. And I've seen it based on what has happened from bringing them in?
Yeah, I've seen, kind of going around, I've seen us move from a place, people often ask me, how'd you get this done? And it really has been a journey from skepticism to belief to utilization, right? As I look at this. But, now when I look at a physician and basically say, maybe that nursing home that had a 30% readmission rate for that particular heart failure population, we got two choices. We can re-educate them, right? Send over a whole team and basically talk about what they're doing wrong or not doing wrong. Or we can say this patient population doesn't belong at this particular nursing home, right? We were able to get it down to that level of looking at, in a very easy format that was, that doctors could really understand in a way that I feel like I never was able to convince them in the past. But this was like, here, look at this. It's very obvious. It's versus national norms. It's versus local norms. It's versus, everything. So I talk about that skepticism to optimism to utilization kind of movement that our physicians took. And, other people say, how do I do this? Like, how do I move along that journey? Like, what advice kind of, how did we do it and what would you tell them?
I would say the main challenge, and then again, of course, there is so much promise, and the issue of acceptance and adoption is, as a physician community, and even the rest of the healthcare workforce, we have never been trained in this mindset, right? So as a result, we didn't have the visibility of what could be possible.
So I just need to embed myself in medical school? Is that what you're telling me?
I would say the operational and the general physician leaders have little visibility on the computational sciences and the predictive analytics. It's basically challenging, at least as a physician, not to rely purely on my intuition. And that can always be a big challenge in saying, I know my patients are at risk, and I'm saying, well, actually, you're 70% right, and you're missing 25% here, and 25% that you thought were high risk actually are not low risk. So again, that has been a major shift that is truly needed. But clearly, what these type of tools is helping us, I would say, separate the chaff from the wheat and give us a clear indication from a patient's perspective. If my mom's hospitalized, I really want to know which nursing hospital will have the best outcomes. And I think so it also meets our requirement from a patient's perspective. So clearly, as far as I would say from an ACO, where this is the mission, vision, and I think so extensive appropriate resources allocated, this is a great tool. The challenge on our side, on the fee-for-service, is can we find the appropriate resources to build the infrastructure? Are there true incentives to move in that direction? And apart from the incentive of doing the right thing, what else can be done to move? I think so that is still an evolving process that will need more input. I would say on my side of the fence in prevention, we see a huge value proposition on so many things. And the EMR is truly helping us because now we have an ability not to look at single labs and medications and outcomes, but a very multimodal approach, putting all of them together. For example, just the simplest intervention in prevention, like statin utilization for patients with cardiovascular disease, extremely suboptimal. But now with these analytics, we have an ability to do a deep dive to not look at the patient, physician, system, and societal levels. And actually, that's guiding us where the resources are going. And we got a big NIH grant just to study this and implement it. One of the biggest challenges that's happening is in the diabetes world. How can we prevent people moving from pre-diabetes to diabetes? It's almost kind of the same analogy. We have too many admissions. Who are the ones who are going to die or readmitted? We have therapies which are expensive. We have limited attention and time, and where do we allocate it? Prior risk scores were absolutely inaccurate. The reason was we weren't looking at this right thing, because now taking social and environmental factor, taking your geocode spatial and plugging it with the data actually is telling us that 15 of the top 30 predictors were based on that. And it significantly improved our prediction. We're presenting that at American College of Cardiology. Now, as part of that, we are building a whole Texas consortium where the models that we are going to be developing will be tested all across the Texas hospitals to see if we can identify those in the diabetes early and all. So for physicians, I'm saying this is the most exciting time. Get on to the bandwagon. Most of the institutions, especially here, are having projects that in one way or other, like the ACO, the Medicare readmissions, the prevention, the imaging, that has some of predictive analytic digital solutions, AI going on. Get yourself a little comfortable with the basics of data pipelines. What is an AI modeling? You don't need to be a data scientist, but getting some insights will be helpful. The biggest missing piece today is we don't have domain expertise guiding individuals who are creating the tools to see whether they are applicable or not. And partner with data scientists and engineers as part of a new initiative, the Digital Health Institute. We're partnering with RISE for these specific things. The key thing is this is going to be part and parcel of our care, if not in 5 and 10 years. Let's get used to it. It's challenging what we used to think and how we used to think. And only physicians, operation leaders who would get fully embedded into this will be the ones leading. So an amazing opportunity. And I would actually ask, if you have a problem and you think there is a digital solution, come to us. There are so many of resources that we will provide help, but more importantly, we want to hear from you. What are the challenges that we have not anticipated? So couldn't be a more exciting time for physicians to be here.
So, okay, Zach, he threw down the gauntlet, right?
Yes.
He threw it down and basically said, okay, now, hey, this data is great. It's helping me a lot, But if you had to dream, like, what else could he build for you that would even, and I know I throw you, a curveball here, but like, what would it be that would add on here? And is it more specificity? Is it more, is it down to the level of the specialization of they just need follow-up and follow-up in? Is it, give me the best place for them to go? Is it, what would it that you'd like to see to help even better manage this population?
Right. I think next frontier is going to be disease-specific progression. You mentioned diabetes, pre-diabetes, diabetes. We talk about CKD a lot. We have end-stage renal disease, or ESKD, is one of the most expensive populations. They're spending upwards of $100,000 a year or more in their later years in life with the ACO. And what we see is that if we can keep them in CKD3B, we can prevent that progression, we can keep them healthier. But the key is identifying, again, which of those patients are most likely to progress so that you can, like you said, some of the resources are very expensive for keeping people from progressing. So we identify which patients are most likely to progress, send your resources there. I think we've got the same thing in heart failure. You've got the same thing in many other diseases. And so it's identifying which chronic diseases to focus on, which patients within that subset to focus on, and see which conditions are most likely to bring those patients in. What is most likely to bring kind of down their overall health? Let's focus on that and make sure we're preventing the progression of those different diseases.
So I know you've done a lot of work kind of in palliative care.
Yes.
Kind of that end of life. You've worked with CODA, you've worked with HDA, you've worked with a lot of that. What is that risk of mortality and kind of managing kind of at that end? What have you found? People often look for what are successful kind of initiatives that can be taken on in that kind of period with that population.
I think the key that we have found in switching to this predictive analytics company is, identifying the right patients. As I mentioned before, we thought we had a good way to identify patients. We reach out and find out they weren't necessarily the right patients. It's a very awkward conversation if you're reaching out to patients about end-of-life discussion and you have the wrong analytics telling you they're end of life and they're not even close, or you're reaching out and they've already passed away, unfortunately, if things aren't up to date. So identifying the right population of patients, and then for us with both palliative care or getting one step before that and just starting that end-of-life discussion with patients before they're unconscious in the ICU, things like that. It's really talking to them about the different options they have at end of life, explaining that there is a difference between palliative care and hospice care, and that if we are talking about either of these two levels of care, we're not giving up on you. we're providing the right resources for the level that you need at this point in time. And so, with you mentioned CODA, it's a company that provides education to patients. And so there's different tools that we may use, but having patients be able to go through education about what end-of-life care may look like, CPR, going through your chances of survival. What will your life be like after coming back from CPR? Will you have the same quality of life? Having that education given to a patient while they're in still a state of clarity of mind and they can make their decisions, it really changes what their wishes are, allows them to document that and put it into the system. And it changes the way that we assist them and help them with what care they need for the rest of their, healthcare journey. So we've seen a lot of benefits in identifying the right patients, putting the appropriate resources and educational tools in place so that they can make their decisions and we can help to respect their decisions.
So going around, what's kind of one thing that you're the most excited about in kind of the next year of our evolution of predictive analytics, Khurram?
The first is, if you look at the predictive analytics, the basic philosophy has been historically identify risk, resource allocation. I think so. The most exciting piece is moving beyond that and more prescriptive, especially with the LLMs and especially in the realm of value-based care. Now we are seeing technology that's coming, Autobots, chatbots that will actually have those conversation of the follow-ups and guide you through the management. We are actually working on creating one to help educate the patients on statin utilizations, weight loss medications, diabetes medications. So I think so there's going to be some revolutions that's going to come in that space. And the second thing is sensor ability to identify patients who are deteriorating at home much earlier, so that apart from the fact that you have significant resource allocated to follow them up, you can get those signals much earlier. So the revolution is upon us beyond predictive analytics to more prescriptive analytics that will go in.
All right, Zach.
I think we're actually on the cusp of this. We're leaning into this. It's present and very, very near future. But I think natural language processing, reading through everything in the chart and using that not only for the predictive analytics, but also for chart summarization and kind of feeding it to the physician, feeding it to the nurses that are making those follow-up calls. Because as you mentioned before, Dr. Nasir, there's so much knowledge to be taken in by the physician. They're reading through so much of the chart. Then we kind of cut it down to here's a score, here's a red, yellow, green. I think we have to get somewhere back in the middle. It's a green or it's a red because you give that chart summarization and then they can say, you're red, you're high risk, and here are the 5 key factors, even though we know there's 175 key factors behind that really populated that.
And Brenda.
And I would add to that, but I would also go into the quality aspects here.
Yes.
We are identifying how we could potentially prevent some complications in the hospital. VTE being one of them, stroke being one of them, falls is another initiative. Also through the AI with looking for certain patient populations that might meet certain criteria. How do you take that AI? How do you get that summary? And then take your quality teams out there, give them those patients to focus on, develop your programs, develop processes, and really improve quality.
Thanks, Brenda.
That's it for this episode of Innovation Spotlight. If you've enjoyed today's discussion, please share, like, and subscribe.